So our group and others have been big proponents of optimizing primary and secondary prevention and making patients and providers aware of the cardiotoxic risk associated with androgen deprivation. To the same effect, there has been a scientific advisory that was published in the AHA journal called Circulation in 2010, which covered again, the risk, which highlighted the inconsistencies of the data and outlined some important primary and secondary prevention approaches. In 2016, there was again a good publication that was published in Circulation. This was led mainly by cardiologists, and they outlined what we refer to as the Abcde algorithm, which has been extremely important in trying to simplify what we need to do for these patients, both from a provider standpoint and a patient standpoint. So let's go over that one by one. So the A here stands for awareness, just making sure that the patient as well as the providers are aware of this relationship that we've been speaking about, of the cardiovascular risk, of the risk of metabolic aberrations. A also stands for aspirin therapy. Now, just a side note, in 2014, there was a publication that was published which showed there might be a beneficial effect of aspirin, a post-diagnosis aspirin, after patients were diagnosed with prostate cancer in actually lowering prostate cancer-specific mortality. So not only beneficial for cardiovascular health, but possibly also for prostate cancer specific mortality. So just to keep in mind, patients that actually qualify for aspirin therapy should be on an aspirin. Coming to the B of the ABCDE algorithm, the B stands for blood pressure control. Now we have extensive data from SPRINT and other trials. Lower is indeed better. For drug management, we tend to prefer ACE inhibitors in patients that qualify for them. The reason being, not only is there a cardiovascular benefit in diabetics and those with established cardiovascular disease, but again, there was a study that had a signal towards beneficial effects in prostate cancer with delayed PSA failure. The C here stands for cholesterol lowering with statin therapy. The statins, as we know, don't only have cholesterol lowering properties, but have pleiotropic effects, anti-inflammatory properties, properties to stabilize plaque. So again, patients that qualify for statin therapy should be on a statin therapy. The C also stands for cigarettes or smoking cessation. I cannot emphasize enough how important that is. Not only is it a strong and independent negative prognostic indicator for prostate mortality, but also all-cause mortality. So tobacco abstinence is absolutely paramount for these patients. The D stands for diabetes control, blood sugar control, follow ADA guidelines. I would be particularly aggressive in monitoring and lifestyle modification and in drug therapy for those that meet criteria for drug therapy, especially within the first 3 to 6 months of starting ADT. It's really important to pay attention to blood glucose levels. Lastly, exercise. There is now a growing body of literature about exercise, its beneficial effects, not only to attenuate side effects of ADT, which include quality of life, body composition, fatigue, but also now there are studies that are showing us improved cardiometabolic panels and cardiometabolic effects of exercise regimens, both strength training as well as aerobic exercise, 3 to 4 times a week, 30 to 40 minutes. If a patient is completely sedentary, have them start below the target and then work their way up to the target. In a recent meta-analysis, it was shown that patients on ADT with prostate cancer that were exercising regularly improved upper and lower muscle strength. They lowered their BMI and lowered their cholesterol level. So only beneficial effects, a lot of them easy to do, and so patients must be encouraged to do this.